Welcome, JD and Geeta. Very good morning, good evening, good afternoon, whichever time zones everybody is in. Thank you for joining us today. We'll take you through a quick overview of our analytics, decision support, diagnostics in a value-based care setting. So let me start with Geeta. Geeta, in general, can you provide? So I'll ask you to differentiate between maybe pre-COVID and post-COVID as well. But in general, without COVID, can you provide a quick overview of value-based care for our audience?
Sure, happy to. Good morning, colleague. Good morning, JD. Thanks so much for the opportunity to be here. Good morning for us here in the US. So I'm coming to you live from Miami, Florida, where we give sunshine and COVID-19 away for free. So I hope everyone's doing well and being safe. It's really interesting to think about where we are in healthcare now, right? COVID has truly changed the entire world, as I think everyone understands, and as we are doing this conference virtually. So in a nutshell, if I had to break down for you, what is value-based care versus what is the predecessor of value-based care, which is called fee-for-service. So in a really simplistic definition, fee-for-service is I do something and you pay me, right? I do a service and you pay me. So if I do a colonoscopy and I'm a gastroenterologist, I'm going to get, let's say, $100, right? Or 100 rupees, whatever it might be, right? This is a cheap colonoscopy, right? If it's value-based care, we are going to incentivize provider and provider organizations very differently, right? So we're going to look at what we call performance measures. So in other words, any male who turns 50, did you do preventative measures? Were you checking for a family history of colon cancer? Did you do a colonoscopy at the age of 50 as what we call a baseline colonoscopy for preventative screening for colon cancer? These are different measures than just the more I do, the more I get paid, right? Value-based care is really based on value, meaning a high outcome. In other words, we know evidence-based medicine shows us that if we do what is called preventative screening colonoscopy at the age of 50 on all men, independent of family history, we're going to catch cancer way before it becomes time to do any sort of expensive intervention like a surgery or chemo or radiation. So that's it in its simple form, and I'll wrap up real soon, Kali. But pre-COVID and post-COVID, what I would say is that a big issue in healthcare, at least in the United States, has really been around patient responsibility, right? Patient responsibility as well as what are insurance companies willing to pay for. So now in the era of COVID, all of a sudden patients are saying, I shouldn't go to the emergency room, I might get COVID, right? I shouldn't go to the urgent care, I might get COVID. I should really make an appointment with my doctor. I should find out if I have a doctor, who the insurance company has given me as my physician. And oh, by the way, I don't even want to leave my house. So could I do as much as I could virtually? Right, so when we think about value-based performance, COVID-19 has almost accelerated what we have been trying to do for years in the US in particular. Because we have patients who are saying, I have a responsibility, as well as how can I do this in a more cheap and effective way?
Perfect, great. Yeah, exactly. And I think, it's only going to add more prevalence now in a post-COVID era. JD, turning over to you, a quick overview of, in general, minus COVID again, can you provide a quick overview of analytics, clinical diagnosis or decision support space in general?
Sure, Kali. Thanks for the introduction. Hi, everyone. I'm joining from the Bay Area in California. Good afternoon to audience in India. It is a common knowledge that use of analytics is widely experimented today across different use cases in healthcare, be it the clinicians, the financial experts, or even the administrators in the hospitals. For example, there's a lot of research happening to help the clinician predict the onset of sepsis in a patient using analytics. Sepsis is a killer disease, as most of us know. It can kill a patient within 8 hours of its onset. So a tool like analytics can save hundreds of thousands of people, and it can really be a breakthrough innovation. Now, the classic example of use of analytics in a clinical decision support is in radiology, and a lot of experiments, a lot of research is happening around this area. Chest X-ray, as most of us know, is a prime method to diagnose pneumonia and tuberculosis. and it's very prevalent in India again. However, diagnosis from a chest X-ray can often be a massive challenge. And because of several other conditions in the lungs, such as your fluid overload or pulmonary edema, as they call it, bleeding, volume loss, or lung collapse in medical terms, and many other conditions that complicate matters just diagnosing the disease from looking at the chest X-ray. So, amongst many others, L&T is also developing a solution to help diagnose these diseases using the X-ray by using technologies like deep learning and regression and image reconstruction. This solution helps analyze the X-ray, enhance and reconstruct the images if needed, and bring in the collective wisdom of doctors by means of deep learning. Some of the other leaders are working in this area are Stanford ML, Cure AI from our home in India as well, Unanimous AI, Swarm AI, and many, many more. So these are a couple of the examples, Kali, which shows the power of analytics to solve healthcare problems.
Yeah, thank you, JD, and thanks for waking up so early for us today. It's what is it, 5 a.m. On the West Coast.
That's what I've been doing for the last 5 months.
Awesome. Now let's turn to a couple of challenges. So I'd like you to highlight maybe a challenge or two in the value-based care setting in the COVID and the post-COVID era. So today, what are some of the challenges in the value-based care area? Maybe Geeta, you can start from a clinical standpoint, and JD, you can give us from a technology standpoint. So maybe Geeta, start with you.
Sure, happy to. So again, I would say the biggest challenge is data, right? Like everything else. So in other words, so I, as a rheumatologist, if I'm seeing a patient, they might be seeing 3 other doctors, right? And they might be going to 4 other facilities where they get their blood work, their radiology imaging. So how do I get a whole picture of my patient and make sure that I'm practicing in a value-based care environment, right? So if they tell me, hey, I just did a colonoscopy last year, and usually patients say, can you look in your computer, doc, and see it, right? And I'm like, you didn't do it here, and you didn't do it with me, which means, no, I can't see it. So what do? We typically have to repeat it, right? Unless the patient can get the record, can do it timely, based on value-based care metrics, I'm responsible to do my part. And the only way I can control my part is in my area, in my facility. So obviously this is a horrible experience. Anyone who's had a colonoscopy to go through this twice for a patient is unacceptable, right? First and foremost. Secondly, the cost, and thirdly, there are side effects to these things, right? Anything can happen. So this is the number one. So data from an interoperability standpoint remains an issue. Analytics also very important because ultimately we're trying to predict things, right? The more we do preventative measures, the more value-based care, the more value we find in things. We're seeing that with COVID, right? A simple flu shot, whenever we get the vaccine for COVID, there's going to be an enormous amount of goodwill to say, I want to prevent, right? In a way that has never really happened historically. The other big issue is, every clinical case is not the same. So while evidence-based medicine says any male at the age of 50 should have a colonoscopy, the truth in the data is that we don't have a lot of minorities represented, we don't have a lot of women represented. So every patient doesn't follow those models and metrics. So we as clinicians get frustrated when we say, you know what, I know a colonoscopy is not the answer, this patient needs to go straight to surgery, right? Or an x-ray is not the answer, this person really needs an MRI. Because we know clinically, we know from our experience, and we know the particular individual sitting in front of us. So population health is fantastic for the population, but individualized care and individualized health is really between that individual and their physician. And sometimes it doesn't meet the paperwork standards, so to speak. I would say in the age of COVID, a lot has changed, right? Number one, people are not going to the doctor. They're not going to the doctor the way they should. They're not doing their annual visit. Unless there is a real necessity or an urgency, folks are not going to the doctor. We're seeing that with ER volumes being down, revenues being down to the hospital. Again, I think it's fantastic that we've moved to a virtual environment, but not everything can be done virtually. So it really continues to be, how do you get the right care at the right time at the right place? That's ultimately going to drive value. And COVID, for the first time, is making us really emphasize on that place. And it's wonderful that people are not going to the ER unnecessarily, but at the same time, putting off your annual visit, putting off your dental work, putting off your eye check. We're probably going to see ramifications of that next year or the year after, because a lot of preventative things will be missed. But again, everyone's really weighing the risk and benefit at this time.
Yeah, and that's where I think that's right, and that's where I think the data, availability of data, and knowing that how many patients have missed their visits will be valuable for the next year, so that from a predictive analytics standpoint, the doctors can reach out and saying, hey, you missed your appointment last year, it's now time to let's at least get it done, kind of thing. So it's a great point. So JD, how about from a technology standpoint, from a decision support standpoint, challenge or two in the value-based care area?
Yeah, thanks, Kali, and Geeta, for very nicely explaining what is value-based care and how is it impacting healthcare. It's value-based care is the future of healthcare for all obvious reasons. However, I feel there is still a long way to go before it becomes a default option for either the physician or for the patient. Many challenges need to be overcome, and a couple of them are, steady financial revenue streams or the lack of it, and which is impacted directly by the technology, interoperability, and both of them are heavily connected. So I will start with the first, so that I can bring the technology point behind it. Fears about revenue stability and sustainability when adjusting to a value-based payment system are consistently reported as one of the biggest barriers to value-based care. In addition to concerns about unpredictable effects of the revenue, the providers are also facing difficulty in understanding the financial complexities of the incentive programs. The second one, which is the technology interoperability, is one of the main root causes, as I said. Gaps in interoperability resulting in concerns about collecting and reporting patient information, which is really the backbone of the value-based model. If you cannot report the patient information, there is no incentive, there's no reimbursement, the model completely falls upside down. Every stakeholder, like Ovaya said in the beginning, that today in the healthcare ecosystem, everybody is talking about putting the patient in the center of the universe. However, there are problems in collecting the data from all relevant sources for the value-based care model to work. Physiological data from medical devices, data from labs, imaging data from PACS, EMR data, and patient adherence data. These are coming from different sources, different devices, different ERP systems or software systems, and none of them work seamlessly just like that. It's not a plug and play yet. So it is not working for anyone yet, and there is significant scope for technological innovation, and that's where all our technology companies can really help. Thank you.
Yeah, that's a great point. I think we've covered the area itself, the challenges. Now maybe let's talk about the promise of diagnosis, clinical diagnosis, analytics in this area, especially in the post-COVID era. Maybe start with you, Geeta, in terms of apart from the obvious the appointments and things like that. Maybe can you shed some more light in terms of what does another promise from an analytics standpoint?
Sure. Again, I think it's about, and it really is. It's really about the right care at the right time at the right place, right? So if we have the data and we have the analytics, we're able to say, Mr. Durgampudi needs to have his blood pressure checked next week at home, because his numbers are trending in a way that is concerning, that he might develop hypertension, right? And we're able to action that data. Then we get that result, and we're able to say, this is really looking suspicious. You need to come into the office. We need to do some blood work. We need to check on your kidneys. And then we're able to take an action there, right? If there's an adverse outcome there still needs to be an intervention. Then we might say, hey, you know what? You need to go to the hospital now. And you need now you've become a candidate for a procedure that could have a life-impacting intervention, right? What happens now is all of that gets missed. Right? All of that information gets missed, and a person with hypertension, often their first symptom is a heart attack, a stroke, and they end up presenting the very first time in the emergency room and ending up in the intensive care unit, when all of these things could have been very easily intervened, very cheaply intervened. But it comes down to education, health literacy, and then monitoring, and then someone being able to make the right intervention at the right time, right? Initially, when you're looking at numbers, there's no need to even come into the office, right? Things start looking suspicious, you need some kind of in-person intervention. Okay, let's do that, right? But the point is, you should not be presenting to the emergency room or the ICU and forget money, forget quality metrics, right? That individual's life has changed, right? So we look at the outcomes, which is what we all look to measure. What is the quality of a healthcare system? This is a poor quality experience, right? For that individual that could have changed and becomes then an expense on society, as well as a quality of life issue.
Exactly. Yep. Perfect. So, JD, from a data collection, data aspects of it, in the especially now, home healthcare devices being used, home data devices being used. Can you talk about how the multiple data sources in under multiple environments are coming together to fuel analytics?
Yeah, so thanks again, Kali. So promise of predictive analytics and AI is huge for medical sciences. A lot of research has been going on for many years. The COVID situation has actually prompted everyone to significantly accelerate adoption of some of these technologies. If you were to consider, let's say, settings like urgent care, chronic disease management, reducing visits to the hospitals are almost discussed every day. Every news channel you open, every information that flows through to your phone, you will see it's being talked about. Now, AI-driven or predictive analytics-driven solutions can really bring massive benefits to this care setting. I'll take a couple of examples of a concept called digital twins. It's been talked about, its promise is a future, which is why I would like to bring it in here as well. And it is essentially predictive analytics application. Let's say in case of chronic kidney diseases, how and where you live and how you take care of yourself makes a huge difference. In the scenario, let's say, a digital twin solution using longitudinal person data, like your genomics data, your behavioral data, and even your social determinants. And added to that is your patient data, which is your imaging and the vitals of the labs. If you fuse these two data sets together, it can really help the doctor make crucial decisions that can avoid a transplant or even delay a dialysis. So in today's context, as a result of this, the patient can avoid hospitalization or even visits to the dialysis clinic can get reduced significantly. So that's really is an amazing development in this context. Another example of use of digital twin is in treating prostate cancer, let's say, for example. I'm picking up some of the chronic diseases that it can solve. The treatment options for such a disease range from surgery to radiation therapy, less invasive options like hormone therapy. A digital twin encompassing a patient's imaging records, lab results, and genomic data, and combine that with a model of the prostate cancer clinical pathway, it helps to ensure optimal decision making about the treatment options. And that can reduce the number of visits to healthcare facilities significantly for a patient who can avoid going there in today's context. So those would be some of the examples of the promise of AI in this context.
Perfect. Yeah, see, I think so it's obvious that data is going to be the key. It's obvious that aggregation of all the data sources is going to be key. And so from a technology standpoint, whoever's working out there on data sources, let's make sure that one, we have data interoperability, the access to data, real-time access to data, which is also based on, even if it's telemedicine, edge computing, all of these, we have to ensure that the data is widely interoperable and available. Now, a question from the audience. So maybe Geeta, maybe this is to you. How would telehealth plus data impact, the value-based care paradigm? So, especially with telehealth. But maybe we'll wrap up with this question due to lack of time.
Sure. I mean, this is clearly what we're seeing in the age of COVID-19. I think it's a beautiful solution. If I have to advise someone where to invest, this is the place to invest, right? So exactly the scenario I gave you where there is some suspicious activity and intervention that's being made, you can action that patient virtually in a very sort of low effort, automated way to make an intervention at home, assess the situation, and determine what is then the right next step, right? This is a not expensive visit. This is an easy interaction and convenient, and most likely the patient will be compliant, right, with a virtual visit. And you have now met the patient in their home. I mean, there is no better place. The most dangerous place is the hospital, right? Second dangerous place is like the nursing home. Third is the doctor's office, right? The safest place is always going to be your home. So this is where we always want to meet the patient, and it brings the cost of care down. It also allows for a really quick and immediate, without any delay, right? In medicine, we say time is myocardium, right? Time is we can't reverse time, just like everything else. So when you can make a timely intervention, this is going to be how we bring down the cost and provide value in healthcare.
Great. Yeah, so thank Geeta, and thank you, JD. Thank you enough we can't thank you enough for actually doing this panel with us today. So just in closing, so the key points that we've discussed are, right patient, right care, right time, the availability of data, the interoperability of data, application of AI and decision support onto that data is actually what is going to help in especially in the value-based care area in the future. So with that, thank you to the panel, thank you to Zinnov for hosting us, and we'll conclude the panel and turn it back over to Zinnov. Thank you.
Thank you, everyone.